And now I'm delighted to introduce our last speaker, Dr. Jan Leerink. Dr. Leerink is an internal medicine resident and PhD candidate working in the group of Leontine Kramer at the Prinses Maxima Center in the Netherlands. His research focuses on blood biomarkers for early detection of cardiac dysfunction and risk prediction models in childhood cancer survivors. He is also co-leading an effort that is for the update of the International Guideline Harmonization Group Cardiomyopathy Surveillance Guidelines. His presentation will describe research that investigated refining the 10-year prediction of left ventricular systolic dysfunction based on initial surveillance echocardiography results. Dr. Leerink.
Yeah, thank you, Melissa, for the introduction, and thank you very much for the opportunity to present my work here today. So today I will talk about our publication that was published in JACC Cardio-Oncology, and it's about refining the 10-year prediction of left ventricular systolic dysfunction in childhood cancer survivors. So I will start off with a short introduction and the rationale for the study, and then I will continue with presenting the methods and results of the study, and then finally a conclusion. So as you probably all know, the survival of children with cancer has increased considerably. And currently, 5-year survival rates currently exceed 80%. But we also know that 60% of the treatments that is used to cure these children is potentially toxic for the heart. And the most important toxic agents are in childhood cancer are anthracyclines, radiotherapy, and mitoxantrone. And from large cohort studies, we now know that almost 11% will develop severe heart failure within 40 years after cardiotoxic cancer treatment. And this risk does not seem to decline after that time point. And we also know from these large cohort studies that children treated with higher doses of anthracyclines or higher doses of mitoxantrone or higher doses of radiotherapy to the chest region are at highest risk. And also that children who develop or adults who develop hypertension, diabetes, or dyslipidemia during their lifetime are also at an increased risk. And because of this elevated risk and because of the potential benefits of early detection and treatment of asymptomatic cardiac dysfunction, current guidelines recommend to perform an echocardiogram at least every 5 years in children treated with cardiotoxic cancer treatments, and potentially more often in high-risk survivors. So the current way we think of risk stratification for cardiomyopathy in childhood cancer survivors is based on a fixed model over time. So it's based on cancer treatment exposures. So high-risk survivors are treated with anthracycline dose above 250 or a high chest radiation dose. Moderate risk survivors are treated with anthracycline dose between 100 and 250 or a chest radiation dose between 15 and 35 gray. And low risk survivors are treated with a anthracycline dose below 100 or a chest radiation dose below 15 gray. But this model does not allow for a change in risk over time as survivors age. So we thought that it might be possible to refine this risk stratification based on echo results obtained during follow-up. So as you can see in this figure, survivors are grouped into a high risk, moderate risk, or low risk group according to their cancer treatment exposures. But at 5 years after cancer diagnosis, they will all have an echocardiogram. So why not use this echocardiogram to refine this risk? With this echocardiogram, for instance, patients in the moderate risk group with an slightly abnormal echocardiogram can change to the high risk group, and whereas children with a normal echocardiogram can potentially have a decreased risk thereafter. So this model has two potential benefits. So the first one is that it allows for a change in risk of cardiomyopathy over time. And the second one is that might help to personalize the scheduling of surveillance echocardiograms, where you can think of earlier echocardiograms in higher risk survivors and less frequent screening in low risk survivors. So this was the main thought behind our study, which was published in the JACC Cardio-Oncology about refining the 10-year prediction of left ventricular systolic dysfunction in long-term survivors of childhood cancer. And the study question was, can we use a surveillance ejection fraction at more than 5 years after cancer diagnosis to refine the risk stratification for cardiomyopathy in childhood cancer survivors treated with anthracyclines or chest radiation? And to do this, we built a prediction model and validated it in an independent cohort. The derivation cohort consisted of 299 survivors from the Emma Children's Hospital in Amsterdam, and it's located here in the Netherlands. And this is one of the most beautiful places in Amsterdam, the Rijksmuseum. And the validation cohort consisted of 218 survivors from the Radboud University Medical Center, which is located in the southeast of the Netherlands. We included survivors without a diagnosis of heart failure or ejection fraction below 40% before or at the first available surveillance echocardiogram, and they had to have at least 2 surveillance echocardiograms available. So they had to have echocardiographic follow-up. And they had to have a surveillance according to the current International Guideline Harmonization Group guidelines. So this means that the interval between each echocardiogram had to be 5 years or shorter. And the outcome of the prediction, what we tried to predict, was the time to onset of left ventricular systolic dysfunction, defined as a left ventricular ejection fraction below 40% after the initial surveillance echocardiogram. And the reason we chose this ejection fraction cutoff is that it's because an ejection fraction below 40% is the threshold for prescribing heart failure medications in the general population. So we built 2 prediction models and compared their predictive performance. And the first model was a Cox regression model, which predicted an ejection fraction below 40% with the predictors anthracycline dose and chest radiotherapy dose. So this is the current treatment dose model. And the second model was just model 1, but then with the initial surveillance echocardiogram added to it. And we assessed discrimination using the integrated area under the curve. And this is a weighted average of time-dependent area under the curve measures over time. We also assessed calibration of the models, which means that we assessed whether the predicted and observed risk were in agreement. And we also assessed reclassification of survivors to a higher or lower risk group in model 2 compared to model 1. And we internally validated the model and externally validated the model in an independent cohort. So the first result of our study is that survivors with a low to mid-range ejection fraction, so between 40 and 49%, are at an 8-fold increased risk of developing an ejection fraction below 40%, which is clinically meaningful because they have to be treated with heart failure medication. And this was an adjusted risk model that was adjusted for anthracycline dose and chest radiotherapy dose. And this 8-fold increased risk is comparable to the risk reported in the general population. So what about the predictive performance? In this slide, you see on the left, you see the model with only the treatment doses, so only anthracycline and chest radiation dose, the way we currently do risk stratification. And on the right, you see the discrimination of model 2, which is the treatment doses, including the ejection fraction at the first available surveillance echocardiogram. And as you can see, the area under the curve increased from 0.74 to 0.87, which was also highly significant. And you can also see on the row below that in the validation cohort, there was a comparable increase in the area under the curve, which was also significant. And on this slide, you can see the calibration of our model, the final model, including treatment exposures and ejection fraction. And as you can see, we had a reasonable calibration in both cohorts, with only a slight underestimation of risk at the higher predicted probabilities in the validation cohort. So how can we use this model? By using we can use this model. In this slide, you can see that on the Kaplan-Meier plots, and we separated survivors into a low and a high risk group. And the low risk had a 10-year probability of below less than 3%. And the moderate to high risk group in red had a 10-year probability of more than 3%. And as you can see, in the low risk group had a there were almost no events in the low risk group. And this represented 3/4 of, so 75% of the survivors, so very large group. And those with a predicted risk below 3%, so the low risk group had a very low risk of developing cardiomyopathy with a negative predictive value of more above 99% in both cohorts. So in this large low risk group of representing 75% of the survivors, we could think of decreasing the surveillance frequency. So this figure illustrates how using an ejection fraction at the first surveillance echocardiogram can be used to refine the risk groups as currently defined by the International Guideline Harmonization Group. So in blue is the low risk group according to the IGHG, in yellow the moderate risk group, and in red the high risk group. And most notably, as you can see, in the moderate risk group, those with a normal echocardiogram have a predicted probability of less than 3%. And those with an slightly abnormal ejection fraction of 48% have a risk that exceeds the 3% level. So based on echocardiogram, you can either have a very low risk of developing cardiomyopathy within 10 years, or a significantly higher risk in the moderate risk group. And we also built an online risk calculator so that you can calculate this risk yourself if you in clinic. So here we calculated, you can fill in the ejection fraction, the anthracycline dose, and the chest radiotherapy dose, and you can see that with this combination, the risk of developing an ejection fraction below 40% is very low, so below 3%. So this would be a low risk survivor according to our model. So there are some limitations to our study, and the first one is that it's a retrospective study. So echocardiograms before 1999 were not available to us. So, and this resulted in that the first echocardiogram that we used for our prediction model was performed at varying time points after cancer diagnosis, with a median of 17 years. And ideally, you would want to have to use a surveillance echocardiogram at 5 years after cancer diagnosis, or at least all at the same time. But this was a little bit variable in our study. There's also, of course, a potential for selection bias because we only included survivors with echocardiographic follow-up available. However, we also did a sensitivity analysis where we waited for the probability of being included in the study, and this analysis showed comparable results. The third limitation is that we had a small number of events in both cohorts, but we did validate it in an independent cohort. It would be good if it's also validated in a larger cohort from another country. So to conclude, the initial surveillance ejection fraction is a strong predictor of a clinically meaningful deterioration in ejection fraction, of subsequent deterioration in ejection fraction. The initial surveillance ejection fraction can be used in addition to anthracycline and chest radiation dose to improve the 10-year prediction of an ejection fraction below 40%. And the multivariable prediction model that we built can be used the most important use of our multivariable prediction model is that it can be used to identify a large group of low-risk survivors in when the surveillance frequency might be reduced. So future directions of these prediction models are to potentially add additional predictors, so blood biomarkers, strain echocardiography, EKG parameters, modifiable cardiovascular risk factors, or even genetic variants. And what would also be, another thing that would be very interesting is to also model longitudinal changes in biomarkers. So, because it might be much more informative than just one single baseline measurement. With that, I would like to acknowledge my PhD supervisors, my co-authors, and my collaborators in cardio-oncology. And I'm happy to take any questions.